there, future RTs. Welcome back to VRS RT Study Hall, where I break down what you're learning in class, and I'll give you some practice questions at the end. I'm your host, Erin Cox, and you'll find more interactive content that goes with this podcast at www.myvrs.com. Today, we're talking about something that every RT student has heard in lab and clinicals: ventilator alarms. Those alarms can feel stressful at first, but once you understand what they mean and how to respond, you'll realize how helpful they are in identifying a problem quickly and why you're important as the ventilator expert. Here's the truth: nursing and other healthcare team members are also very intimidated by ventilator alarms, and they will be looking to you to fix the problem. Alarms are extremely important, and they require you to set them, just like your other ventilator settings, so don't forget them. They have default settings when you turn the ventilator on, but they are often way outside of what they should be. Alarms are there to tell you that there's been a change in the patient's breathing, so you need to make sure that they are set to a point where you are alerted when things go outside the bounds of where they should be. There are guidelines on how to set alarms. However, there's also real patient care. Every alarm should be set to each individual patient, but there's also hard limits to where things should be. We'll spend a few episodes talking about alarms, but we'll start with the high pressure limit, probably one of the most common ones. So first, how should it be set? The golden rule is 5 to 10 centimeters of water above the measured inspiratory pressure. Now, it does matter if you're using pressure control or volume control as to what is most appropriate. In pressure control, the pressure is set, so the alarm should be closer to what it is set than not. In volume control, pressure is going to vary, so it's appropriate to go to 10 so that you don't get nuisance alarms. That's when the vent alarms, but it's not really an issue. You should also have a hard limit of about 40 for most patients. Higher than that, and you may be risking barotrauma, which is trauma to the lungs caused by high pressures. It's going to alarm when the inspiratory pressure reaches that set point, and it's also going to end inspiration and cycle into expiration. It's not going to allow any higher pressure than that alarm limit to be delivered to the patient. So if the patient is in volume control, then inspiration will end, even if the set tidal volume has not been delivered. This means that you might get a low volume alarm at the same time as high pressure. If this occurs, it is important that you understand that the issue is really high pressure, and you need to identify why that is happening. So what can make inspiratory pressure high? It's anything that causes increased airway resistance or decreased compliance. That will cause pressure to increase. You want to quickly assess the patient and the circuit. If the patient's vitals are relatively stable, you can move on to troubleshooting. If they aren't stable, then you should always remove the patient from the ventilator and provide manual ventilation. This is true for any alarm that is sounding. In a high pressure limit situation, manual ventilation can sometimes help you identify the cause. If you bag the patient and they improve, well, then the issue is in the circuit. Maybe you have a clogged HME, for example. If the patient does not improve, then the problem is in the ET tube or further in the patient's airway. When you're troubleshooting in a clinical or lab situation, you're often looking at many things at once. You can usually easily see if the patient is biting the tube, if they're coughing, or if there's water in the circuit. But on tests, there is sometimes a certain pathway you should follow, and it's important to consider all of the information given to you. You should really listen to breath sounds first, and that may be given within the question, along with some other assessments. That can point you to the right answer. If the patient has rhonchi, suction. If they have wheezing, give a bronchodilator. If breath sounds are absent on one side with a tracheal shift, a pneumothorax is likely present. If you have crackles bilaterally in the bases, potentially consider pulmonary edema. You want to consider everything that is given in the assessment to help clue you into the problem, just like how you would use patient assessment in real life. If breath sounds are very decreased bilaterally, consider attempting to pass a suction catheter to assess the patency of the ET tube. If you can't pass the catheter, then there is a mucus plug, and you need to replace the ET tube quickly. If you can pass the catheter, then suction. Secretions might be clogging the ET tube. That may be your cause after all. You should assess the same way with a tracheostomy. However, a couple of things to consider here. First, if there is a disposable inner cannula, replace that rather than the tube itself. If there is no inner cannula, you can replace the trach tube with an obturator if it has been at least 7 days since its initial placement. However, when the trach is very new, it needs to be replaced by the surgeon. In these cases, you should remove it, cover the stoma with Vaseline gauze, and consider intubation with an ET tube, particularly if ventilation remains something that needs to be critically addressed and the physician is not immediately on hand. One thing to consider if the trach was just placed and there's decreased breath sounds, significant distress by the patient, high pressure, low volume alarm, development of crepitus, then the tube may be misplaced and requires adjustment. Sometimes you can rule things in or out as possibilities if the alarm is sudden versus pressure that has been increasing over time. Pneumothorax and pulmonary edema are ones to put in the more sudden category alarm, along with biting, mucus plugs, kinks, coughing, any kind of occlusion that can happen quickly. Pathologies like pneumonia, atelectasis, and ARDS are usually something that is worsening over time. They will cause a high pressure alarm if you allow it to get there, but it's better to address increasing pressures before you actually hit that limit. And don't forget to look at the patient. Large swings in pressure may cause a more intermittent pressure alarm. Look at your ventilator graphics and the patient in these situations. If the pressure scaler looks scooped, that could indicate dysynchrony that requires an increase in inspiratory flow. Or if all settings are appropriate and the patient is anxious or agitated, you may need to consider sedation. Also, being in significant pain can cause the patient to not be in sync with the ventilator. The point is to really pay attention to all possibilities. Patient assessment is key, and that really requires you to look and listen. Okay, let's test what you know. First question, how should the high pressure limit be set? It should be 5 to 10 centimeters above the measured pressure. Remember to use closer to 5 when in pressure control and 10 when in volume control. Question 2, if the high pressure alarm is sounding and the patient's vitals are not stable, what should you do first? You should manually ventilate the patient. Question number 3, if you manually ventilate the patient and they suddenly improve, what should you do next? Look for an issue in the circuit, including the HME. Question 4, if you listen to the patient and hear rhonchi, what should you do? You should suction. Question number 5, what about wheezing? Give a bronchodilator like albuterol. Question 6, what if you note that the patient has absent breath sounds on the left and a tracheal shift to the right? You should be thinking pneumothorax. Your next choice will depend on if the patient is decompensating. Prepare for needle decompression. Question 7, if you want to assess the ET tube or trach for patency, what should you do? You should attempt to pass a suction catheter. So question 8, what if you can't pass the suction catheter? You need to replace the ET tube. If it's a trach, you can replace the inner cannula if one is present, or replace the tube with an obturator if the airway is older than 7 days. Question 9, what if it has only been 48 hours since the trach was initially placed? You need to remove the tube, cover the stoma with Vaseline gauze, and intubate. Question 10, here I want you to try to think of all the things that can cause a high pressure alarm. You're looking for anything that will increase airway resistance or decrease compliance. Airway resistance will be anything in the circuit or airways. Compliance can come from alveolar issues or something that is pressing against the chest wall. It could be coughing, biting, kinks, plugs, bronchospasm, inflammation, patient agitation, pneumothorax, pneumonia, ARDS, pulmonary edema. It may seem overwhelming with all of the possible causes, but remember, if you're performing a good patient assessment, you should be able to identify the cause based on that. Remember to look first. Look at the patient, look at the monitor, look at the circuit, look at the graphics, then listen. Breath sounds can tell you a lot. Then consider any additional ventilator measurements or diagnostics that might be needed. That's it for this episode. Head over to www.myvresp, that's myvresp.com, to find the full ventilator bundle, or this information can be found primarily in the Introduction to Modes, Settings, Alarms, and Measurements course. You'll find the link in the description. You can also find RT Study Hall on Facebook and YouTube. In the next lesson, we'll cover some more alarms. In the meantime, happy studying.